My guest today is Professor Gautam Menon, who is Professor of Physics and Biology and Director of the Center for Climate Change and Sustainability at Ashoka University, India. He is also Professor of Theoretical Physics and Computational Biology at the Institute of Mathematical Sciences in India. Welcome, Gautam.
Thank you, Gill. Pleasant to be here.
Yeah, thanks for doing this. So our topic of conversation today is COVID-19, especially COVID-19 in India. And you've been writing a lot about this over the last, I guess, 18, 20 months now. It feels like a lifetime.
It's been a long time.
And so in April 2020, you had a piece, COVID-19 pandemic, should you believe what the models say about India? And in which you said the 21-day national lockdown that Prime Minister Narendra Modi announced in his address to the nation on March 24th ends on April 15th. What happens next? So I guess in April 2020, in India, there's sort of an optimism. Things sort of we took care of it, and things are sort of dying down. Was that expectation?
I think it just wasn't very clear. I mean, there was this discussion that maybe the government had overreacted by having a shutdown. And of course, the shutdown wasn't just till April, it actually went on further. There were 2 points where it was successively extended. It was really, I think, only by the end of May, end of April, beginning of May, that we had sort of end to shutdowns, and then things began to open up. The numbers weren't very clear at that point. It was clear that there were cases, but we're talking about cases at the range of 500 to 1,000, 1,500, going up. I mean, they were still somewhere less than 10,000 at that point. And it really didn't seem as though things were going to get dramatically worse. But this has to be understood in the context of a very, very strong and very harsh lockdown that really was enforced pan-India with great seriousness. And that, I think, did help to stem the numbers. And that may have led us to some sense that this had been conquered, which probably wasn't true.
Yeah, so I don't know if you looked into this, Gautam. Sweden, for example, had a slightly different policy. They were sort of relaxed early on. Their cases sort of went up a lot higher than other Scandinavian countries and Europe. But it seems like less lockdown seemed to have helped them in the long run. Do you see that sort of a thing happening in India too?
No, I mean, sort of, if I go back and think about it, and we sort of look at what happened in that context, I think the lockdown did prevent things getting out of hand at that time. And I think it did manage to, I mean, lockdowns really only help in suppressing the curve, but they don't really change the total number of people who will wind up with the infection. That's the understanding. The moment you lift the lockdown, but you have some people left in the population who can infect other people, those numbers will rise again. So lockdowns are really to be understood as ways to build in health infrastructure, ICU beds, oxygen, etc., to prepare for what might come later. And then you also induce your population to be as careful as possible, having scared them with the lockdown earlier, to mask, to reduce crowding wherever possible, so that you don't have to deal with large numbers. To some extent, I think that is what happened. The effects of the lockdown lasted very long. And the only point you saw the increase, the gradual increase, and then the peak for the first wave came around the middle of September. The incipient increase really was sensed by about August. But that peak wasn't very high by the standards of what came later. It was a little less than 98,000 cases per day, new cases per day. And overall, I think there was some success. I think not an unalloyed success. There were many, we're not counting the total cost of the lockdown, but I think it did help in providing a breathing space and preventing cases from rising too rapidly, which really, I think, is the purpose of the lockdown.
Yeah, I mean, that's the point, isn't it? It's sort of buying time so that you don't run out of hospital capacity. You can maybe reduce mortality if people are taken care of, and so on. But there is a sort of a real trade-off, especially for a developing country. When you have a lockdown, it has a huge economic cost. And so sort of a policy perspective, where do you come out? So I'm looking forward to the next iteration, Gautam. I don't think this is going to be the first, the only one. when you come out in early part of the policy prescription, lockdowns versus some other type of intervention?
I think the general public health understanding is the lockdown is the last thing that you should do. And you should only do it if you think that the situation is going to go out of hand. And at that point, when the government made the decision on the 24th of March to institute the lockdown, they were looking at the example of Italy, where already you had ICU stretched to capacity, you had triaging of patients, because not all of them would be able to live through a COVID-19 episode. Of course, there's a difference between Italy and India. Italy is a much older population on average, the oldest in Europe. India is a young population with a median age of about 28.5, 29 years. And the disease hits very asymmetrically by age. It's much worse for older people, much milder for younger people, although there are still, it's not as though you can't have severe consequences if you're young. But still, relative to an older person, you're in much better shape if you're young. And I think it was the example of Italy that I think worried the government. They did not want a situation like that. I mean, no government likes the sort of publicity that would ensue if you have people who cannot get hospital room, cannot get oxygen, cannot get treatment, and would die as a consequence. So I think they may have overreacted, but they were looking at something when they did that. They were looking at modeling exercises that suggested that you could have very large numbers of people infected, a huge strain on hospital capacity. And I think that's what led them really to make this decision at that point. Whether it was good or not is a counterfactual. It's hard to say.
Yeah.
I mean, we can't run life's experiment again just looking at that. But I think now, with the sort of benefit of hindsight, I do believe numbers might have got out of hand, which they didn't finally at that point.
Yeah, I mean, that's an important point. So distancing, masking, if you get high compliance in those sort of preventative mechanics, then you don't get to a situation that you need a lockdown. So there is a threshold beyond which you're saying you do really have to step back and have a lockdown. Otherwise, things are going to get completely out of hand. But that preventative aspects could actually avoid a lockdown, right? If you do it properly.
They could have, but then you have to sort of make inferences about how seriously your population will treat a public health message that says, wear masks, go about your work, don't crowd, shut down enclosed locations, etc., etc. I mean, that really is, I mean, we now know much more about COVID-19 than we did in April or May of 2020. We now know that we don't have to worry about surfaces and touching surfaces and so on so much. It's an airborne disease that moves very rapidly. The best thing that you can do is wear a mask, especially a double mask, triple mask if possible, and concentrate on ventilation. The crucial importance of ventilation was not understood at that point. So unless you deal with ventilation, you would have had cases going out. You would have people sort of under the impression that they were being compliant with what was known at that point. But we didn't have the full information at that point, especially that this is a respiratory disease that transmits very rapidly in badly ventilated conditions and can move between people, and sort of you can have one person infecting a large number of people if they're just confined in a small location with bad ventilation. So, looking back again, we didn't know that, but the lockdown did prevent that sort of situation and the consequent shutting down. It's a very hard decision. I mean, I don't think that the government made it lightly. To shut down essentially commerce and the economy for such a protracted period. Essentially, to do this over a whole country of the size of 1.4 billion people is not a trivial exercise at all. I think there was a lot of thought that went into it. Looking back, with whatever sort of hindsight one can muster, that I think that worked out as a positive, and especially in the light of what we saw in the second wave, and I think we'll probably get to that, which was actually very, very traumatic for the country.
Yeah, I just want to touch on one thing that you mentioned. So the average population age in India is about 30, right? You said?
A little less. The median is about 28. Yeah, the median is 28, yeah.
And so since age is a big factor in mortality, we would have expected lower mortality, maybe we'll touch on it later, lower mortality in cross-sectional metrics in India. But I guess the complication is we can only measure case mortality, not infection mortality. And so I guess our denominator, or we don't really have a good idea what the denominator looks like for infection, right?
Yeah. So if you imagine this going in an unrestricted manner, And you imagine very conservatively that with the old version of the virus that existed in 2020, in early 2020, if you imagine that given the number that we knew then, about 60 to 70% of the population would have been infected. That would give you something like 500 to 600 million, let's say, it's just as a ballpark number. And even if 0.1%, or which is a reasonable estimate for what the infection fatality ratio for someone in roughly the age bracket of India, somewhere between 0.1 and 0.3. That's still a very, very large number because that is 600 million is a huge number. It's twice, it's a little less than twice the size of the United States. So even a small percentage of that very large number translates into an unacceptable number of deaths. And that's really the problem.
And so would you say that India's infection mortality, if we knew all the numbers, is a lot lower than worldwide averages?
So this number has been moving around. So our own estimates that we do from modeling have a number like 0.1%. The sort of numbers that come out from the West are around 0.3 to 0.4, 0.5%. Some part of this is just the fact that the ages are different. That mean that the UK, the US, etc., typically are skewed towards a median age of around 40, between 38 and 42, 43, etc. And much of Europe is in a similar position. India is young, Bangladesh is young, Pakistan is very young. Pakistan's median age is about 22 or 23. So that accounts for some fraction of the difference, but not all. Increasingly, what's being realized is that India severely undercounted its deaths. Whether this undercounting was more substantial in the first wave or the second wave is not completely clear, but at least it seems to be that really, the first wave, maybe we undercounted by a factor of 2 to 3 or something. But by the time we got to the second wave, we were undercounting by a factor of 5 to 8. This is a rough estimate. You have estimates that are all over the place, but all of them agree that that the undercounting was fairly large when looked at over the span of the entire pandemic, the 18 months odd of the first wave and the second wave of the COVID-19 pandemic in India. So that, if you did that calculation correctly, would you get an IFR that would move towards non-Indian values, Western numbers? That's possible. My own personal feeling is a 0.1 to 0.2 is probably the right IFR for India and for countries in this region. For example, Singapore seems to have seen fairly few deaths despite a reasonable number of cases. And that suggests that well-managed populations where you don't allow the cases to spiral out of control will tend to have lower IFRs. And that may really be the difference, although it's hard to say at this point what exactly the truth is.
Right. Yeah, so now I want to move forward to 2021. So you have a piece, the novel coronavirus variants and India's uncertain future in April 2021. You say the number of COVID-19 cases in India increased at a relatively slow pace after the first case was recorded on Jan 31st, 2020. And daily cases peaked at about 98,000 cases around September 15th, declining steadily for 5 months thereafter. A month into 2021, it seemed possible that India's experience would be unlike those of the US, Brazil, and other countries. But then we got the second wave. Are we sure the second wave is really led by variants?
So that was the point of my article. I was trying to synthesize all the information that we had at that point. And I was looking at modeling, the modeling that we were doing, the modeling that other people were doing. And it seemed increasingly inescapable that this had really very little to do with what happened earlier. India had been opening up, if you look at Google mobility, since November, December, January, there was a sort of steady increase in people's mobility. But between January and February, or between mid-December and February, there wasn't all that much of a difference. Certainly nothing to say that it's just people throwing caution to the winds, going out, mixing completely with each other. That should have happened earlier if it was the same type of virus. So it wasn't mobility, but it seemed to be something that was in very characteristic ways, very different. The signal that something new was going on were these reports from the state of Maharashtra, where you had whole families being infected and test positivities in the realm of 50%. So roughly 1 out of 2 people were testing positive for COVID-19. So this was spreading at a rate that was unprecedented. If you looked at any of what happened earlier, it was happening in a background of people having mixed at the same level for the last 2 months. So then it seemed inescapable, and there were slowly reports coming in of INSACOG, which is the government sequencing organization, reporting new variants, especially a new variant called the Delta variant. And that seemed to be driving a lot of the dynamics. So I think that article of mine was probably the first to say in public, to make it very clear that this was a point of discontinuity from the past, that something new was happening and that could almost certainly be ascribed to the new variants. And especially the one that was first seen in Maharashtra, now called the Delta variant. It had a different name, and this is the 1.617, as it was originally known. And it's a subvariant of that is really called the Delta variant. But it seemed to me at that point, and slowly to be, although I perhaps the first to articulate it very explicitly in that article, that something had changed and we had something new to worry about.
So I know a lot about this, Gautam, but when you have competing variants in a disease, typically the more virulent, the ones with higher mortality dies off, and the ones with higher transmission survives because the one with high mortality, the host dies, you have less chance of transmission, right? I know the Delta variant is more highly transmissible, but I don't know if there is data that shows that its mortality rate is any lower. What do we know about that?
So as far as we know, I mean, the whole sort of science on this is a little unclear. The clinical information is a little unclear. It seems reasonable to say that it's not very different from the original variant that was there earlier in terms of mortality. So it's not as though you have a drastically different IFR from a Delta infection than you had earlier. It's likely that the sort of increase in death that you were seeing in India was just a consequence of the fact that many more people were coming into hospital and they couldn't be treated. And as I say, people died, but they didn't have to die. They died because they could not access the sort of treatment that would enable them to have stayed alive. Now, regarding going back to what you were saying, that the general trend of what you said is correct, that people believe this, but it's not true for COVID-19 for a very specific reason. Much of COVID-19 transmission happens before you show symptoms. So what happens to you after that? Once you transfer the virus to someone else, evolution is least concerned about what happens to you. The job of evolution is to propagate the virus increasingly between people. And if of course you die before you can do that, then that's a dead end for the virus. And that's why it's argued that viruses should evolve towards greater transmissibility and lesser virulence. But that doesn't seem to be true, or doesn't have to be true in this particular case, precisely because you transmit the virus, you're infectious to other people at maximum before you yourself begin to show serious symptoms and possibly even mild symptoms. So the virus doesn't care about that, and evolution doesn't care. It's happy if you die after that because the job is done.
That's really interesting. So if that is true, then we would expect. I mean, I don't know if we picked up all the variants. We picked up a few. There may be hundreds of variants at play, right? And all of them may have higher levels of transmission, but no less mortality potential. And so I think you have another piece, which is, is COVID-19 becoming endemic to India? So it used to be a pandemic, but are we getting into a situation that this is, it's going to be there for a long time? What's your sense of that?
I think epidemiologists are increasingly beginning to think that it will be there for the long term. It's not going away. There's no possibility of eradication or elimination. It will stay with the population for a while. I think what I tell people who ask me this question is, you have to understand that everyone will get infected sooner or later. The only question is, will you get infected before you're vaccinated or after you're vaccinated? If you're infected after you're vaccinated, then you will blunt very considerably the effect of that infection. But if it happens before you're vaccinated, then depending upon your state of health, your immune response, your age, and a variety of other factors, you could have more serious outcomes. What's clear now is that vaccinations do protect you from far more severe outcomes than you would have if you were not vaccinated. So finally, I think if we would move to a situation where everybody has been vaccinated, we may have to take booster shots every 2 years or 3 years, and is able, COVID-19 will, for most people, be something that you can shake off in a few days. It will be a fever, it will be an irritating cough, but within a few days it will go. There's nothing that really tells us that the thing should last. There are precedents. There are other coronaviruses closely related to this one that are responsible for varieties of the common cold. The other reason why it's hard for COVID-19 to go away is that you have animals can also be reservoirs, so they can move from human to animal and then come back in some modified form. So it's not just as though treating humans and through some measure of isolating every human from every other human, that you could actually get rid of this. We have complicated interactions with our environments, with what surrounds us, with the natural world. And I think COVID-19 has hit that sweet spot of high transmissibility, relatively low virulence, that will enable it to carry on for as long as, and we will, I think humankind will have to live with it.
So vaccinations are going to be critical, critical in many aspects because we have this thing called long COVID, and the long-term effects of a severe infection is quite problematic. A lot of effects on the central nervous system. I was told that a couple of million people who survived the Spanish flu in 1918 had Parkinson's 10 years later. I mean, we are just 2 years into the cycle. And so the objective function really has to be get vaccinated as fast as possible. It is likely at some point people will get infected. But if you have antibodies, you won't get sort of a severe infection, as you say. And that has huge beneficial effect, not only on the individual, but also on society. So vaccination appears to be a really critical thing, right? I want to go ahead. Go ahead.
No, absolutely. You summed it up very well. Vaccinations are critical, and our aim should be to get as many jabs into as many arms as possible, and that's important for India. And I think since you refer to vaccinations, Indian vaccinations have really gone to the level of something like around 10 million every day at the moment. There was a peak where it hit 25 million, which is unprecedented in any other country of the world. But that's the number that we're talking about. And with those numbers of vaccinations, with supply now more or less guaranteed from the Indian suppliers at least, we can hope to vaccinate a substantial fraction of the Indian population certainly by November, December, and then make sure that we do the second dose as well within a few months of that.
It's a bit of a culture change in the sense that I think the compliance to flu vaccine in India is like 2%. In the US is more like 60, 65%. The other 35% is not getting any vaccination. So that's a bit of a problem. But on average, we have high compliance to flu. So this is, in the Indian context, if this becomes sort of an yearly issue, there are infrastructure requirements. I mean, 1.4 billion people, 70 a billion people getting vaccinated every year is in itself is a big issue, right?
No, it is a big issue, but I mean, we've shown that we can do it. For example, we have very, very successful child immunization programs, childhood vaccination at numbers that are, impossible to imagine anywhere else in the world. So Indian public health systems have shown that they can vaccinate at scale. We'll have to figure out how to do this, this extended boosters, maybe 2-3 years. We don't know enough about the immunology. Is a booster required for everybody or only for people above 60 or people who are immunocompromised? Maybe it will turn out that we don't need boosters, that having a vaccination or a prior infection will do you for about 5 or 6 years, maybe even more. We don't know that yet. That's certainly a possibility. And it may be that we need to reserve our boosters exactly as the US is doing for people in the elderly segment of the population, people who are immune compromised. Hopefully, we will learn a little bit more about the medical side and the immunological side in the weeks and months to come. And that will certainly decide our policy. But I don't think there's anything inherently impossible in India being able to vaccinate such large numbers on a continuing basis because we do something very similar in our huge scale childhood immunization programs.
Right. The other possibilities are we might get a broad spectrum vaccine that is effective against a large number of coronaviruses, or we could get effective treatments that can take care of the problem fairly quickly. So all those things are happening to some extent, and so it's really buying time. It's the issue. You have to get through a situation where you don't really have enough defenses, but the defenses are coming. It's just a matter of time, but you have to get through it, right? That's the real thing.
Yeah, you're absolutely right. You're absolutely right. And the development of antivirals is a fairly complicated business, and it's not that easy. But there are, of course, other types of treatments. Monoclonal antibodies work, and they seem to work fairly well, although they're an expensive method of treatment. the ideal, the holy grail would be a broad spectrum, thing that targets coronaviruses of this generic type, and where you don't have to worry about minor changes in variants and changes in sequence due to variants, but sort of looks for parts of the virus that are independent of those variants, and therefore it works much. I mean, but let me just emphasize, I think, to your listeners that what we have done with the medical science, the immunology, the basic science required to get us to the point where you have vaccines with a 90% plus efficacy, and these were developed within a year. Of course, this rests on the back of a huge amount of work on similar areas earlier. It rests on the fact that we did encounter SARS, the original SARS, in the early 2000s. So work around that, work on MERS, etc., all helped to get us where we are. But we now have new vaccine platforms, such as the mRNA vaccine platform, that seems to work extremely well and can be repurposed in interesting ways. So I think what we have learned from COVID-19, from the challenge of designing vaccines for COVID-19, is actually something far more important and will stretch beyond COVID-19 in terms of our being able to treat in novel ways diseases that have stayed with us for a long time.
Yeah, thinking about the endemic aspect of the coronavirus, as I mentioned, Gautam, my parents still live in Kerala. I grew up there. I have been puzzled right from the beginning with some of Kerala's numbers, and especially the mortality numbers. Clearly, as we talked, case mortality is not a very reliable metric because of the denominator problem. But if you compare Kerala against its neighboring states, its case mortality is 1/3 or something like that. And so I was thinking, this idea of endemic infections, is this a region, they get a lot of monsoon, I remember the sky opens up and rains for 3 months and everybody gets the flu. Repeated infections over a longer period of time, is it creating some sort of a protection against COVID? Do we know anything about that?
It's possible. That was raised early on. In fact, it was when Indian cases began to come down after the 15th of September. And it seemed as though, everyone expected, including me, that the festival season in the north and the east of India, in Bengal, Delhi, etc., the marriage season, the festival season, would lead to a spike in cases. That didn't happen. There was a sort of gentle little peak and then it came down. A very, very gentle peak. So all of us were then searching for reasons for why this might be happening. And one reason at that point, which is popular, is that maybe Indians, South Asians, etc., live in fairly unhygienic surroundings. Maybe this means that our natural immunity is bolstered. And there is this idea called the hygiene hypothesis that an immune response is conditioned by the level of sort of hygiene that you have, the level of exposure that you have to bacteria, etc., which is why you see relatively fewer numbers of cases of autoimmune disorders in this part of the world compared to, say, for example, the US or Western Europe. So the idea was that that relatively low levels of hygiene in India might help to blunting an immune response. And the bad parts of the COVID-19 is really your immune response over-responding or being overactive, which leads to more severe consequences than might otherwise have been imagined. But you must set that against the fact that the moment the second wave happened, we knew that that was not true, that there was nothing that protected us, and that was very classic epidemiological disease sweeping through a population that was completely naive to it. And this is just something that just spread far more efficiently between people. So there's no reason to believe that Indians are special at all. I think I wrote a piece about this, saying that Indian exceptionalism is not the case. That it was foolish to believe that that might have been the case, because this was, when you say a novel virus, it's novel for everybody. No one has seen it before. It comes from an animal. It comes to you from its original source, where it was perfectly happy living in a bat, and then some intermediate animal, and then it made the jump to a human being, which is completely defenseless against it. So there was no a priori reason to believe that Indians might have been special. We were not exceptional, or that anyone in the world would have been special in that respect.
Yeah, unfortunately, we have 8.4 billion clones walking around the Earth. Any new thing is going to affect everybody. There was another hypothesis about the BCG vaccination. It sort of emerged from Eastern Europe, where they saw significant difference between Eastern Europe and Western Europe. and BCG vaccination had higher compliance or higher prevalence in Eastern Europe. Do we have any Indian data on this?
That's been studied, and I think the sort of prime argument against it is to look at India and Brazil together. Brazil was very, very hard hit by the epidemic. And both India and Brazil have fairly large level, both of them BCG is mandatory in both of these countries, but that doesn't seem to have protected them at all from the virus. So this, these people have many ideas. Most of these ideas came in the beginning when the original first wave in India was just taking off, when we didn't have an idea of what were we counting deaths correctly? Of course, we knew we were not counting cases correctly. The factor of 20 or 30 between detected cases and actual cases. And we weren't even counting deaths correctly. And that factor may have been somewhere between 2 and 5. So with these large uncertainties, it's hard to see where the protective effect of BCG might have come from. There's no strong immunological reason to believe that BCG might be protective. Had it worked out, it would have been an interesting idea, but there doesn't seem to be any evidence in its favor at all at the moment.
Yeah, so I want to touch on the Kerala numbers and your piece on paradox of those numbers one more time from a policy perspective. So my understanding is that it looks like Kerala did a good job early on. They brought things down to almost a trickle. And then the second wave, they really took off. I understand half the cases in India is from Kerala. So from a policy perspective, what do you see there? What can we learn? What was done correctly? What was not done correctly?
So so this is where we get into politics a little bit, because people use Kerala as an example of saying cases are running right there, whereas cases in the north of India have come down, so they're obviously managing it better in the north versus the south of India. I think Kerala did a very good job of managing its pandemic within its constraints. And the reason is, it's just a reason of numbers. When the ICMR, the Indian Council of Medical Research, did its sero surveys, Kerala had the lowest fraction of people with antibodies at the point where the survey was done, about 2.5 months ago, which means that there were fewest people infected as a fraction of their population in Kerala. That number was 44%, when UP, Bihar, MP, etc. were in the 70 to 79% bracket. So the reason that those states are doing well now is because they just let the infection rip through with untold consequences in terms of mortality, which of course you won't see if you don't count the deaths correctly, in terms of cases, in terms of people who couldn't get attention. So these are all now, as a consequence, now because so many people have been infected, and any reasonable guess now would suggest 80 to 85% of people infected in states of Madhya Pradesh, Rajasthan, Uttar Pradesh, Bihar, the northern states, Delhi, possibly Punjab as well. Whereas Kerala, having relatively small numbers, you compare 44% to 70%, having relatively small numbers of people who were infected throughout both the first and the second wave, is now paying the price. Because as I said, the thing about COVID-19 is that you will catch COVID-19 invariably sooner or later. The only choice that you have is to catch it before you're vaccinated or after you're vaccinated. That's essentially it. And Kerala is now on a simmering thing. It has lots of people to be infected. It has about 50, 56% odd people who can be infected by this. So the infection will be sustained by these pockets of people who will remain susceptible. The good thing about Kerala is these numbers have not gone out of control. There was no point at which Kerala ran out of ICUs, ran out of oxygen, whereas that was the site that was seeing through much of the north, including Delhi, including Uttar Pradesh, Lucknow, many cities, where people were just turned away from hospitals because hospitals could not accommodate these numbers. Whereas that did not happen in Kerala. So that, I think, is again a win for Kerala. It kept through various combinations of both rigorous measures by the state, as well as, very importantly, people taking it seriously. That, I think, was crucial, local governments and individuals taking this very seriously, that it managed to keep the cases from rising too fast. It's always important to reduce the cases as much as possible. So that's where I think they're not doing such a good job. They should have come down with the iron hand to push those cases down, because as long as there are cases in the community, people will fall ill and people will get it, they will give it to other people, whatever you might do. So the priority for Kerala right now should be to reduce those numbers from the current 20,000 odd to something like a few tens or a few hundreds per day, which is the more manageable number. It hasn't done that, but it's done everything else correctly.
Yeah, and the beauty of India is that there are 30 different experiments being run.
Exactly.
And so we have a wide cross-section of policies and the effects of those policies. So at least on the surface, correct me if I'm wrong, Gautam, at least on the surface, it appears optimum policy is Obviously, any sort of preventative things people can do, take it seriously early on. The more you prevent, the less you're going to run out to a threshold level. At that point, you have to have severe actions like lockdowns to bring it down. The idea would be sort of flattening the curve till you have some sort of a defense against it, so that you don't get the severe disease, right? So that still seems like the optimum policy for everybody.
Yeah, that's absolutely right. That's a very good summary of what it is. It's a novel disease. You have no defenses against it. All you can do is to prevent it spreading to other people at a rate that is faster than a rate that you can control. And at all costs, you don't want to run out of hospitals. You don't want to run out of ICUs, oxygen cylinders, etc. So critical care of any sort. So it's imperative to keep the numbers down at a level that they don't begin to intersect the limits that you have on healthcare capacity. Healthcare capacity, of course, in India, if you're in a big city, it's better. If you're in a remote rural location, it's much worse. So part of our understanding now what happened with COVID-19 is the distinction between what was happening in the cities where the television cameras were pointing at the hospitals, we had a better idea what was going on, and the sort of disaster that spread through rural India. So especially parts of the north of big cities of UP and Bihar, hugely populated, states of UP and Bihar, hugely populated, where you had villages where you had people, whole villages falling ill from all that we know, but unable to access medical treatment. In fact, scared of the medical system and what it might do to them, and therefore not willing to go out and seek treatment. And that, I think, is again, that level of hesitancy, I think, is a problem. And we have now to rethink the way we think of public health. Public health, put back the public in public health in a serious way to ensure that we strengthen primary health care across the country, especially in rural areas, to make sure that something like this doesn't happen again.
Yeah, another phenomenon, I don't have clear data on this, Gautam, so I want to get your perspective on this. So if you look at Mumbai, for example, it seems like the slums got hit first. And in different cycles, the disease sort of moved to the suburbs, moved to the higher economic classes. It's almost like not even COVID can avoid India's caste system in terms of infections. What is sort of the basis of that phenomenon, do you think?
This is actually true across the world. It's also true in the US, it's also true in the UK that you have minority populations who are socioeconomically backward relative to the dominant majority population at that point. They always suffer disproportionately more from COVID-19. So it's not peculiar to India. I think that the richer you get, the easier it is to insulate yourself from other people, to make sure that they don't pass infection on, to buy masks, to ensure that people around you are rigorous in the use of masks and in COVID-related precautions. In a tiny, cramped slum in Dharavi with 10 people and within a few square meters of each other, it's very, very hard to do that. And the lockdown prevented any mixing at that level, so it sort of the disease spread rapidly through the slums, much more slowly in the high rises and the upper class localities. But that was true for the first wave with the milder, less transmissible variant of the original wild type of the virus that existed pre-December or pre-January of 2021. But once Delta came over, Delta erased that distinction very rapidly. So then you could see the numbers for the high rises in the slums, the high rise numbers just going up and equaling the numbers in the slums, simply because it's just very hard to get away from the Delta variant. It just transmits so easily. So even a chance encounter in a lift, you're wearing masks, but you're in an enclosed location, or you're a little careless about who comes in and goes out. The earlier variant of the virus was a little more forgiving of that. The Delta variant is completely unforgiving. If there's any niche, any point of entry, it will find it, which is just a reflection of the fact that it is far more transmissible than the earlier virus. So that, I think, is what happened. We ironed out the difference. We also, ironed out the difference between rural and urban India. Urban India was much harder hit in the first wave than rural India, but that discrepancy was made up by the time we got to the second wave, which spread very rapidly through rural India, and therefore that's where the real undercounting of deaths came from. With deaths we have no record at all, because these happened in underserved areas where numbers were just not recorded very well. It's only now that we're beginning to realize the extent of that undercounting.
Yeah, so this is a true sort of public policy issue, right? So again, I'm thinking if there is another iteration of this, how will you manage that? I mean, we now have an expectation that people close together, lower economic strata is going to have a higher level of infection early on. And so, from a public health policy perspective, what are sort of the interventions one could take?
So there were various interventions that were tried both in Delhi and in Bombay specifically, where you had local, mohalla level or sort of locality level clinics, and people were encouraged, if they had symptoms, they tested positive, to go to large centers that were run by government, which could hold about a few thousand beds together. So they had a bed, place to shower, bathrooms, etc., where they could go and be away from people at home, so they did not transmit the disease to people at home. COVID-19 is a strange beast because you can be completely asymptomatic. Most probably 30 to 40% of people can be asymptomatic for the disease, but nevertheless carry high enough levels of virus in the mucous membranes to be able to transmit it to other people. That's what makes it hard. If you had people who were symptomatic right from the beginning and sort of severely ill, you can then, it's very easy to locate them. It's very easy to ensure that they're isolated, and people they came into contact with are quarantined. With COVID-19, it's impossible to do that unless you have a very, very regular testing regimen. And to test an entire area the size of Dharavi with a population of probably close to 1 million or more is a public health nightmare. So I don't think there is a way that can be done, that can actually be done. It's no, I don't think it could be done anywhere in the world at some level, to ensure that you can test people early enough that you catch them even when they're asymptomatic, even if you have all of the infrastructure to take them, put them away, and isolate them so that they don't transfer it after that to other people. The bottleneck really is our ability to test. And that's a problem that's not just in India, but throughout the world, because of the strange nature of COVID-19.
Yeah, you sent me another piece, Gautam, optimizing testing for COVID-19 in India. You say COVID-19 testing across India uses a mix of two types of tests. Rapid antigen tests are relatively inexpensive point-of-care lateral flow assay tests, but they're also less sensitive. And then you have the PCR test that is more sensitive and more specific, but it takes time and it's more expensive. And so it seems like, yeah, as you say, there is an optimization question there. you have two varieties of tests, one not so good but very quick, one very good but not so quick. So how do we optimize this between these two types of tests?
Yeah, there's another point that PCR test is also more expensive.
More
By a
expensive.
factor of about 3 more than the RAT test. So that's certainly another axis on which you can change things. So what we intended to look at in that modeling study was the fact that many states, including the big states of UP and Bihar, also Kerala, were using more than 50 or 60% of the rapid test, the fast but not so sensitive test, compared to the PCR test. And they were getting a lot of flack for that from political things, saying that, look, you are going with a sensitive test, you're going to miss cases, you should be doing PCR, etc. But nevertheless, given the numbers that they were dealing with, shifting to a PCR regime would have multiplied their costs manifold. And this is money that perhaps could have been diverted to treatment, to oxygen, etc., and as a potential better use of handling more severe patients if they actually made it to hospital, or they made it to a state where you could actually treat them. So we wanted to look at this trade-off. What is the trade-off between the sensitivity of the test, how much you test? Suppose you could test 3 times more than you're doing at the moment, or 5 times more. Where is the sweet spot? And then, of course, also the cost of that, the relative cost of the PCR and the RAT. So we put a lot of numbers in there for what they were across the states. And these numbers have been dynamic because states and central government have been negotiating down the rates of the PCR test so that they're somewhat cheaper. But they're still probably at about 2.5 to 3 times the current cost of a rapid antigen test. And the rapid antigen tests have been improving. So our main result from there is a somewhat surprising result. And that is, it doesn't matter, as long the sensitivity of your rapid antigen test doesn't matter, provided it's beyond a certain level. Let's say 50 to 60% is okay, provided you compensate by testing much more. And right now, I mean, at the point where we wrote the paper, India was testing a little less than 0.1% of its population every day. Now numbers are around the same, but then total number of cases have dipped to much lower. We were saying at that time, you should have been testing about 5 times more. If you could test about 0.4 to 0.5% of the population every day, then it didn't matter. The distinction between RAT and PCR didn't matter. So the instruction to the states would have been, you can use RATs, go right ahead and use RATs, so simply test more and use a differential in the cost in order so that you can test more. And we found a whole bunch of interesting things. First of all, we found that delays in returning in the RT-PCR tests were actually terrible. And at the peak of the second wave in India, the delays in between being tested, first of all, it was very hard to get a test, but even if you got tested, it was 3 to 4 days before the test result came back to you. So these delays can be absolutely, devastating in terms of your ability to control the epidemic. So that's where the RATs come into play. That's why the RATs are very important, because they give you an instant result. And you can trade off the lower sensitivity of the RATs compared to the PCR because you're testing large, you're testing more numbers of people, and therefore you can slow the progress of the pandemic down. That was our main result. And we pointed out that this is a model that also applies to other low and middle income countries, not just India, because this is a generic trade-off. Expensive test takes time to deliver an answer. Cheap test, point of care, 15 minutes, and is also cheaper. So how government should use their testing, I think this is an important sort of idea of how to structure policy around testing that's applicable not just to India, but to a host of countries in a similar position.
Yeah, it makes a lot of intuitive sense. Multiple things there. One is India has a large number of people. So the larger the number, the better your sort of, cross-sectional understanding by rapid testing, even if it's not highly sensitive. The other is if you don't have the luxury to wait in seclusion post-test, and it takes a couple of days to come, and you're just walking around,
Exactly.
before the
Exactly.
test kit, it doesn't really help, right? I mean,
exactly.
And so, so looking forward, then some sort of even more rapid test, some saliva or something that people can just quickly do it at home or somewhere like that seems like a pretty interesting thing. I don't know if anything like that is in the works.
I think there is a lot of work like that in the works that people are looking at. They're looking at these breathalyzer types of things where you can breathe in. And based on nanotechnology, you can identify traces of virus in the breath that as you breathe out. And that can again give you an instant result. Cheap paper-based tests that look at saliva and you can test is one way, for example, to open schools in an unrestricted manner. You just make sure that kids are tested every day when they go to school or at least fairly regularly. And you can thus make places overall, public places safer. Imagine testing everyone who goes to a football game or something like that. You can make sure that the people who are in the game are aware that they're in a safer environment than they would have been otherwise. So that's certainly one direction to take. And I think these technologies, if we can develop it for COVID-19, we can do it for other things as well. And that I think is really going to be important, the game changer in the way we approach many other infectious diseases. The ability to retool, the ability to use tests that are simple, cheap, customizable, point of care. That I think is going to be important in the future.
Do you think this will have a little bit of a difference on the flu vaccine? What I'm thinking is that because the symptoms are similar in many cases, when you get a flu, it sort of creates a perturbation in the system, right? You might think it's COVID. So do you think as part of the COVID-19 vaccination, perhaps a flu vaccination sort of kicks into higher gear, or you don't see that?
It's possible that you can administer these vaccines together. I think that has been raised at some point, that you can sort of deal with both of these sort of fast spreading respiratory diseases at the same level. We've made a fair amount of progress in controlling flu. If you look at, for example, the southern hemisphere across last year, across 2020, they barely saw flu season at all, just because people were wearing masks, washing hands, avoiding contact, etc. So I think those lessons I hope will stay. And just increasing mask wearing, making it a little more common. If you have a bad cough in the day and you're going and you need to go out for something, you wear a mask. This is very, very common in the Far East, in countries like Japan and Thailand and Singapore, etc. Where you see people wearing masks under normal circumstances. They may just feel a little sniffy on that day. They don't want to infect other people, so they'll wear their mask as they go about their business or stay at home altogether. I think the challenge will be to get the West to reach a similar level of mask acceptance, and that I think will automatically have an effect of controlling the spread of flu, in sort of certainly making a difference to that. And I think now people may be a little more disposed to taking flu vaccine, given their experience with COVID-19, the fact that they are similar. And that's where I think public health should push forward. That's another example.
Yeah. Japan is another example. So, high average age, but mask wearing is culturally completely accepted. And so I think both their incidence rate as well as mortality, given their age in the country, was substantially lower than what would have been expected, right?
Yeah. So again, I mean, Japan is sort of a complicated thing. They were very worried about the Delta variant, which also seems to have got there now. But again, because mask wearing is so generic, because cleaning public surfaces, mask wearing, and all of these were existed at some level even before COVID-19. Many of the countries of the Far East have an experience of SARS and from the early 2000s, and so they know what it means to be prepared for an epidemic, and they take it very, very seriously. Hong Kong, Singapore, Thailand, all of these countries were affected at that point. So in a sense, the new precautions for COVID-19 were not very different from what they had prepared to do 15 years before that, when the last SARS came along. But you're absolutely right. There is a cultural acceptance of mask wearing across much of the Far East that is absent across pretty much anywhere in the West. And hopefully there will be some level of convergence with the West moving towards an idea that wearing a mask is not a fundamental infringement of your personal freedoms, but something that you do as part of society to protect other people as well.
So what's the situation in India, Gautam? How do people feel about mask wearing? In the US, as you know, a group of people here who wouldn't wear masks at all. So what's the situation in India, generally speaking?
I've seen fairly high mask compliance. Now it seems to be tapering off a bit. I mean, it's also exhaustion. People have been under some level of restriction related to COVID for 18 months, and that's a long time. I think levels of mask wearing still remain high if you go outside. In fact, in the institution where I work at Ashoka University, it is mandatory to wear a mask in any public place, in any public area. And that, I think, has been sustained through fairly rigorous measures. If you go to an airport, a station, etc., this is certainly enforced wherever you go. I mean, wearing a mask is irritating. It scratches your nose, etc. But I don't think there are sort of fundamental arguments against masks in India, at least on the grounds of my individual liberties being infringed, where the government has no right to do that, which I think is much more of a feature of the US and parts of Europe. So I don't think there is that opposition to wearing a mask. People are fairly willing to wear masks, especially if you explain to them what the function and use of that mask is.
And are there any sort of religious objection to it?
Not that I've seen, and I think overall, sort of religious leaders in the country have been very proactive about ensuring that their followers do follow COVID-19 protocols. In fact, there've been fairly stringent restrictions on temples and on churches and mosques, etc., in terms of people gathering together. And this has, no, I mean, no, as far as I can see, no religious leader at all of any significance whatsoever has come out and said that this is discriminatory, this should not be done, we should not, as a matter of religious observance, we should not wear masks. So that, I think, has been a very positive aspect of how religious leaders in India have responded to the COVID-19 pandemic.
Yeah, so I want to finish up with your other recent piece, India's COVID-19 data and the public interest. You say here the media preoccupation with urban India served to hide the more substantial tragedy that is unfolding across rural parts of the nation. We touched on that before, but could you talk a bit about sort of the scale of this? So, the data coming out of the country was very focused on, as you say, urban areas. We didn't really know what was going on in the rural parts of the nation. So what is, 18 months into it, what is sort of has our knowledge increased in terms of what actually happened in rural India?
In somewhat indirect ways. And what's happened is there's been a lot of outstanding reporting from data journalists such as S. Rukmini, who's an independent data journalist, reporters. I think there's the Reporters Collective, the Hindu newspaper, the Hindustan Times, all of whom have spent a fair amount of effort in just trying to dig up data that is available in public sources. So looking at the civil registration system of the CRS, which records all deaths, and looking for excess mortality. If you look at a benchmark of 2015 to 2019, did something unusual with respect to that benchmark happen in 2020 and 2021. And that's where you begin to see that there is this huge discrepancy in the numbers, that somehow excess mortality pointed to numbers of excess deaths that really should largely be attributed to COVID. That was somewhere between 5 and 10 times. In fact, in some states, it was sort of mind-bogglingly large, that discrepancy. So that's the only real handle we have at the moment, together with, of course, reporting. And when at a time when state governments were saying that, no, we don't have not seen too many deaths, we're managing fine. But reporters who were stationed outside morgues, outside crematoria, were recording the steady stream of bodies coming in to be burnt or coming in to be coming into the morgue. And so that this dissonance between an official number and what was seen on the ground was something that has really come up in absolutely outstanding reporting. This is reporting at a time when governments have been very, very sharing of admitting that anything was wrong with that mortality numbers were high, etc. And even now, I don't think there has been any official admitting of the fact that many more people died than have registered as official COVID deaths. It's important for multiple reasons. So, in rural India, it's, because overall India's accounting for its deaths is not very good. Although about 80% of deaths are registered in some way or the other, only about 20% of the 80% do we have a cause of death. So it's piecing all of this information together. Kerala records well, Tamil Nadu records well, the north, parts of the north don't record too well, but some other states do. It's a strange mix of numbers across India. But I think so to give a bottom line, currently I think India has about 450,000 official deaths, roughly speaking. I don't know what the exact number, it's roughly in that ballpark. The actual number of deaths, putting all these estimates together, running statistical tests on them, etc., is somewhere between, let us say, 1.5 to 2 million at its most conservative end, and 5 to 7 million at its most extreme end. So the truth is possibly somewhere a factor of 7 to 8, maybe even 10 times the official number. That's roughly what we understand at the moment, but you can see that this is a fairly large band. And it's important for us to try and understand what that number is. It's important for people to achieve closure in terms of what happened in this, for it not to be lost in the midst of history, but to have a better accounting for this.
Yeah, so 500,000 approximately official number, maybe 10 times that is the actual number if you look at excess mortality.
Yeah.
And so that compares, is that similar to EU? And I guess, again, we cannot really say case mortality, right? I mean, how does it compare to the rest of the world?
If this number is true, this would automatically catapult India to the country with the largest amount of mortality anywhere else in the world.
In aggregate. In aggregate.
The total number. If the actual number was somewhere near 4 million to 5 million, that would be larger than any other country in the world. And that would certainly be very significant for India. The numbers, I don't think other countries have seen such a large discrepancy, countries in the West. In the US, there is a discrepancy, and certainly in the early part of the pandemic in the US, there were many deaths, for example, in care homes, etc., where people died, they were not accounted for as COVID-19, but they were almost invariably COVID-19 deaths. It's a little later that since now, the default would be to test for COVID of anybody, to test if there's anything even remotely like COVID, if they had symptoms at all, or to test them at that point to see if they should be assigned to be COVID deaths or not. But the deaths were missed in the initial part, but now I think overall the counting is better and the numbers are much more trustworthy.
Yeah, I don't know what, so the Spanish flu 1918, I think it was something like 15 to 20 million died worldwide. This is not very dissimilar at the end of the day. I think we're going to get closer to that number if you count everything from an excess mortality perspective.
That's true, but of course the population of the world in 1919, 1920 was much smaller than the population of the world right now. So it was very hard at that point. And India saw probably between 10 to 20 million deaths in India, and I think the worldwide number is larger than the one you quoted. It's between 50 and 100 million, modulo large uncertainties about these numbers itself. But that, in terms of the population at that time, India with a population of, let's say, about 300 million, 400 million at that point. This was a huge chunk. 1 out of 10 or 1 out of 12 people died in the country. So I think at that level, the bare numbers may be the same. Certainly the impact, as I say, I'd say that COVID-19 is probably the defining public health event of this century. Already, as Spanish flu was for the last century, and although that's still gone back in the hazes of history and in the haze of time. But now that we can record better, now that we know what's happening here, it has an immediacy of having, since we've lived through this pandemic. The effects of this will last for a long time. And I think it's very, very seminal in our history, our understanding of public, our understanding of what pandemics of disease can do in principle.
Yeah, so in conclusion, Gautam, I mean, you have done a lot of work in this. You've looked at all the data. What is the most important thing we can learn from our mistakes, let's call it, in India's policy response to this? I'm thinking, if we can learn from this, we can get obviously better for the next iteration. What do you think that is?
One is strengthen primary healthcare across the country. And of course, there's primary, secondary, tertiary healthcare. And usually, by the time you get to tertiary, you have big, very well-equipped hospitals in the major cities of India, which are really no different from anything that you might get in the West. But the frontier is really where in the villages, in the small towns, etc., can you give them assured public health essentially public health provision at no or minimal cost to the bulk of your population. That, I think, is a challenge. It's been a challenge for many years for the country. There have been many strides that we've made. Our immunization program, as I said, is quite remarkable. But we need to do much more in that. And I think that certainly should be the foundation or the cornerstone on which we build our policy for the next decade, next several decades. The second thing is data. And I and many other people, you mentioned the article that I wrote, but studies of what has been happening have been hampered by the complete unavailability of data that is with the government. This is data collected with public funds, that is out of taxpayer money, but it's inaccessible to the public for analysis. And it's not as though the government within itself has all of the abilities to look at the data from multiple perspectives, from a data analysis perspective, a big data perspective, a modeling perspective, a statistical perspective. All of these skills are available outside the government framework, certainly in academia, in the private sector. So a larger transparency, keeping in mind privacy aspect, would have certainly helped our understanding of what was going on. I mean, it's still the fact that we don't know the number of people who died of COVID-19 up to a factor of 10, I think is terrible. This is something that should have been in place. We should have had better recording systems. We should have made more of the data public rather than trying to hide it. So that would be my second point. The third point is a more global point, that zoonotic diseases such as this that come to us from animals really come because we have destroyed the natural boundaries that exist between human beings and animals. I mean, under normal circumstances, where would you see a civet cat or a pangolin or a thing except in a zoo? But now, increasingly, you're breaking these ecological boundaries. You're deforesting the world at large levels. You will inevitably set up a stage of a conflict between human and animal. You inevitably increase these interfaces between human beings and animals, allowing it or making it possible for these spillover events from animal to human being to happen, of these viruses that are novel, that you have no protection against. So a larger ecological consciousness of what is human beings' place on the planet, what is the respect that they must have for their surroundings, for the ecological surroundings, I think is again very important for the future, not just for COVID-19, but for things that may happen for the future in many ways. I mean, I think that would benefit us in many ways, not just for disease.
Yeah, so healthcare analysis, data infrastructure, and environmental policies. On the healthcare side, I want to touch on one other thing, Gautam. So insurance, healthcare insurance. So one thing, we found higher mortality when you have comorbidity issues. So if you don't really have access to healthcare, you are in a worse shape, and any sort of this type of an issue is going to have a higher impact on the population. What's the situation for access? I'm thinking, more about the rural population. I know that the healthcare infrastructure is not quite there, but even if healthcare infrastructure were there, would people have access to it? Do they have the economics to get access to it? How does it work?
So there's an argument that says that certainly primary healthcare should be available freely or pretty much at the cheapest level that you can get, so that your population, after all, which is what supports your country, should be able to access it. I mean, exactly what form that should take in detail is a little more complicated. Should there be some amount of an insurance component where you pay whatever amount, maybe if it's 10 rupees a month or 20 rupees a month, whoever can pay, can afford to pay, pays that particular amount to support the system? Or should the government just take care of it as they do in many other countries of the world where you pay your taxes, those who pay taxes, and you're guaranteed a level of public health service that takes care of all you need, that you never have to worry, as you do in parts of the US, for example, where certainly the cost of ordering an ambulance is a serious deterrent to being treated. And the fact that you have many people who don't have insurance, health insurance, and they can be treated for emergencies, but not for the sort of routine long-term care that they might require, is something to worry about. So what form and shape that should take in India is still, I think, under active discussion. It's not an area that I'm particularly familiar with, but I would go with the fact that we should be able to guarantee a primary healthcare system that is pan-India and that is available at the cheapest price at all, if not completely free.
Right. Excellent. Yeah, this has been great, Gautam. Thanks so much for spending time with me.
Thank you so much, Gill. Wonderful to talk to you.
Thank you.